Hello, my name is Sait Ashina. I'm the headache specialist at Beth Israel Deaconess Medical Center. I'm also assistant professor of neurology and anesthesia at the Department of Neurology and Anesthesia at Beth Israel Deaconess Medical Center. I would like to talk today about novel therapies in headache management. These are my disclosures. I would like to start with overview of headache disorders and facial pain. This is from International Headache Classification, the latest version. You can see here that the headaches are divided into subgroups: primary headaches and secondary headaches, and also facial pain conditions in the International Headache Classification. Today, I'm going to be talking mostly about migraine and cluster headaches because there are novel therapies for these two headaches in particular. Primary headaches are common in general population. As you can see here, migraine affects approximately 10 to 16% of population. So it's a very common headache. Cluster headache affects roughly 0.1 to 0.2% of population. And the chronic migraine, which is a subtype of migraine, affects approximately 1.5% of population. Migraine is a very disabling condition. It affects 1.3 billion individuals worldwide and is the third most prevalent illness in the world. It is also the most prevalent neurological disorder in people aged less than 50 years, and it can be divided in episodic and chronic. It is most common complaint encountered by neurologists, but it's also seen by pain specialists and other specialists. Migraine is associated with high level of disability and financial burden worldwide. Approximately 2.5% of people with episodic migraine transform to chronic migraine the following year. What is important to note is there are unmet needs. Migraine is underdiagnosed and undertreated. The pathophysiology of migraine is not fully clarified, but we know that there are several mechanisms that are involved in generation of migraine headaches. One of them is chronic or cortical spreading depression, and we know that migraine is also neurovascular headache. The pain probably originates from pain-sensitive structures in the cranial region, such as dura mater, perivascular, sensory fibers. It is also important to note that there are certain peptides that are involved in generation of migraine, and one of them is CGRP. And it is very important to mention that because CGRP is also the reason that we have the novel therapies for migraine. So the treatment of migraine consists of acute pharmacotherapy and preventative pharmacotherapy. But it's also important to note that patient education and non-pharmacological therapies are important in the management of the patients with migraine. There are acute medications for migraine, pharmacological. There are non-specific ones. There are analgesics and non-steroidals. Opioids are not traditionally used for migraine because there are migraine-specific medications. And there are disease-specific medications for migraine. These include ergots or ergot-related compounds. There are triptans, which have been on market since the 90s. And more recently, we have addition of G-pans and D-tans, which I'm going to be mentioning and talking about later. Among the preventative pharmacological treatments, we have beta blockers, we have anti-seizure medications, we have calcium channel blockers, we have some alternative medications, and we do have tricyclic antidepressants and botulinum toxin, which is approved for chronic migraine indication. Now, more lately, we've been adding new medications, and we have now anti-CGRP medications, or so-called CGRP monoclonal antibodies. There are 4 of them, as you see here. And there are CGRP receptor antagonists, small molecules, which have been added for the prevention of migraine. So what is calcitonin-generated peptide? It was first discovered in 1982 by Susan Amara at the University of San Diego. What she found is that it is produced by calcitonin gene, and with automatic splicing, the CGRP is created. And what is later was found that it comes in 2 isoforms, an alpha and beta isoforms, and the alpha one is found in the central and peripheral nervous system. and it coexists with other neurotransmitters such as like substance P, neurokinin A, neuropeptide Y, and etc. Its half-life is very short, and we believe that it is important in the evolution of mammals, and it has preserved its function. We think that initially, from being a vascular peptide, it has become more as a neuropeptide. The immunohistochemical studies have shown that it is found in both ventral and dorsal root neurons. It is found in C fibers and A delta fibers. It is also found in perivascular fibers, which we think is the main source of the plasma CGRP. In addition, if you look at the immunohistochemical studies, both in humans and in animals, it is found in cortex, brainstem, thalamus, cerebellum, and glia cells. So here you see the neuroanatomical localization of CGRP. Now, 50% of trigeminal neurons contain CGRP, and 35% of trigeminal neurons contain receptors. There is a little bit of overlap between the ligand and receptors. And this is very important for migraine pathophysiology, because we know that trigeminal neurons are involved in the pathophysiology of migraine. The C fiber neurons, they contain mainly CGRP, and we know these fibers are unmodulated, and they are polymodal nociceptors, and they signal slow and dull pain. A delta neurons, in contrast, they contain mostly CGRP receptors. They're thinly modulated, and they signal acute and sharp pain. Now, what about the CGRP and migraine? We know that CGRP is released into extracerebral circulation of humans during the thermocoagulation of trigeminal ganglia. This was shown during the surgeries on trigeminal ganglia. And we also know that administration of sumatriptan subcutaneously leads to normalization of elevated CGRP levels and improvement of the headaches. And later, it was shown in the Danish Headache Center, the IV administration of human alpha CGRP causes headache and migraine in patients with migraine. So this has led to development of the drugs, because the studies have led to development of the drugs blocking the CGRP or antagonizing the CGRP. So here I want to show you the difference between the small molecules and monoclonal antibodies. And you can see here that small molecules, the target specificity is much lower. For monoclonal antibodies is much higher. The clearance of small molecules is by liver and kidney, and the clearance of monoclonal antibodies is through the reticuloendothelial system. They're much larger in size, and usually monoclonal antibodies given via parenteral routes, either subcutaneously or intravenously. And half-life of monoclonal antibodies is much, much longer, in contrast to the half-life of the small molecules. Now, let me mention about what we have now of the novel treatments for the abortive treatments of migraine. So here we have two drugs which are currently available on the market. One of them is ubrelvy, which is called Ubrelvy as a brand name. Comes in 1,500 milligram tablets, and recommended dose is either 50 or 100 milligram as needed. Patients can repeat the second dose in approximately 2 hours. The max dose would be 200 milligrams. For patients with severe hepatic or severe renal impairment, recommended dose is usually 50 milligram, max 100 milligram per day. Adverse reactions include nausea, somnolence, sedation or fatigue, and dry mouth. For rimegepant, which is a second drug available on the market, it is oral disintegrating tablet. Comes in 75 milligram tablet. Recommended dose is 75 milligram per day, which is a max 75 milligram per 24 hours. Adverse reactions include nausea, hypersensitivity reactions such as dyspnea or severe rash, but it is very uncommon. So, and the most common side effects we see in a clinical practice is nausea. As I mentioned before, sumatriptan or triptans have been the mainstay for treatment of the migraine, for acute treatment of the migraine. And one of the first drugs available among the sumatriptans was sumatriptan. Sumatriptan is an agonist on serotonin HT 1B receptors and 5-HT1D receptors. And these receptors are usually located on meningeal arteries and peripheral trigeminal neurons. What we have now is we have DTANs, which is, and the first one is lasmiditan. The advantage of this medication is that it doesn't work on the arteries or vascular system. So it's more specific for trigeminal neurons or trigeminal ganglion cells because it is a selective agonist for serotonin 5-HT1F receptor. So lasmiditan is now available on market, and recommended dose is 50 milligram and or 100 milligram or 200 milligram taken orally as needed. Usually recommend no more than one dose in 24 hours. And the most common adverse reactions include dizziness, fatigue, and paresthesia and sedation. Because of this side effect, it is a recommendation now not to drive for 8 hours after taking this medication. So we reserve this medication usually for patients who have disabling headaches, who usually stay at home and would like to have relief and do not respond to treatments with triptans or other headache abortive medications. There are some interactions with serotonergic drugs. So there's a heart-lowering drugs interaction with heart-lowering drugs, heart rate-lowering drugs, as well as there are some warnings and precautions about the CNS depression, serotonin syndrome, and possible risks of medication overuse. Here we have a summary of the symptom or pain relief at 2 hours in the randomized clinical trials of treatment for migraine. On the left side, you see the aspirin, diclofenac, and ibuprofen. On the right upper part, you see sumatriptan. And on the lower part, you see for the newer drugs, for lasmiditan, rimegepant, ipratropium, and they're all been studied in randomized clinical trials, and the efficacy of these drugs have been proven in these trials. Now, let's talk about the monoclonal antibodies targeting the CGRP pathways. There are 4 available CGRP monoclonal antibodies. As you see here, 3 of them are targeting the ligand, the molecule, CGRP molecule itself, and erinumab actually targeting the receptor. And 3 of them are given as subcutaneously, and eptinezumab is actually given intravenously. They all have long half-lives, close to 1 month, and for most of them, you can administer them on a monthly basis, but for praminezumab and eptinezumab, you can also do quarterly. Here you see how the erinumab, or Aimovig as a trade name for the medication is, looks like. It's an auto-injector, and it comes as a 70 and 140 milligram dose. It's administered monthly. It's indicated for prevention of migraine, both episodic and chronic. The adverse site reactions include injection site reactions, hypersensitivity reactions, watch for constipation, cramps, muscle spasms, hypertension, and anaphylaxis. Praminezumab comes as a 225 milligram monthly dose or 675 milligram every 3 months or quarterly dose. And it's also indicated for prevention of episodic and chronic migraine. It also comes as an auto-injector, as you see here. And adverse reactions include injection site reactions, hypersensitivity reactions, rash, pruritus, or urticaria. Galcanezumab comes as 120 milligram injector. Now, it is administered a little differently. Usually we prescribe a loading dose of 240 milligrams followed by 120 milligrams monthly doses. And it's also indicated for prevention of episodic and chronic migraine. Here, adverse reactions include injection site reactions, hypersensitivity reactions, rash, urticaria, dyspnea, and constipation. Eptinezumab is usually given as an intravenously, and it is can be given in infusion centers or clinics which have availability to give infusions. It comes in 100 and 300 milligram dose, and usually the starting dose is 100 milligram. It's administered every 3 months, and it's indicated for episodic and chronic migraine prevention. The common adverse reactions here include nasopharyngitis, hypersensitivity reactions. It is expensive medication, and we usually reserve it for people who have tried self-injectors and have not responded. Just to mention that monoclonal antibodies targeting the CGRP pathways have been studied in phase 3 randomized controlled studies in both chronic and episodic migraine. They have proven to be effective. And here I would like to share some of the data from the phase 3 randomized trials for these drugs. What you see that the results of the studies are very similar among these 4 medications or drugs, and in the primary endpoint, there's a total reduction in migraine headache days per month and up to 2 days, and this is a difference versus placebo in both episodic and chronic migraine patients. Here you see the phase 3 multicenter randomized double-blind placebo-controlled parallel group study of erinumab for episodic migraine. You can see the separation from placebo already happens in the first month, and the results are statistically significant. And just to mention that in this study, the mean number of migraine days per month at baseline was 8.3 days. Here, just to show you to compare to show the comparison to topiramate and onabotulinum toxin A, where results are very similar also for the onabotulinum toxin A and topiramate, just to show that the monoclonal antibodies have similar effect on the reduction in number of days in patients with migraine. These are results for the chronic migraine here on this slide. The second endpoints in the randomized clinical studies were the 50% reduction in headache frequency from baseline. And here, if you look at all studies, we found that there's difference between the active treatment and placebo was up to 20% in phase 3 trials. This is the comparison, 50% response rate in phase 3 trials and comparison between the medications. And this is for episodic migraine in particular here. Now, another secondary point in the studies was the reduction in acute medication days, and it was up to 1.5 days in the studies on average. And here you see the results from HALO trials for episodic and chronic migraine from erinumab. Now, when we assess patients with migraine, we also look at the patient-reported outcomes. We look at disability, how the patients are able to function. Now, what we found with the monoclonal antibodies for migraine, that they do improve patients' disability, headache-related disability, as you can see here, demonstrated by HIT-6 scores and MIDAS scores. Here is that the CGRP monoclonal antibodies in episodic migraine, the early onset, they already work in the first month, and you can see that with pretty much all 4 antibodies. And here to show that the most common side effects in the clinical trials was the injection site pain, and constipation for erinumab. This is the mode of action of monoclonal antibodies, so they can be working on the receptors, and they can also be working on the ligands. Now, the mechanisms of prevention of migraine by CGRP monoclonal antibodies was proposed by our group. We believe that CGRP monoclonal antibodies are blocking CGRP receptors at A delta fibers, and in this way are stopping the migraine pain. But for example, botulinum toxin, we know it works on C fibers, and so the mechanism of monoclonal antibodies is somewhat different from the mechanism of action of botulinum toxin, for example. Now, in summary, we can say that monoclonal antibodies demonstrate efficacy and tolerability across both episodic and chronic migraine. CGRP monoclonal antibodies reduce the acute headache medication use days. They improve the disability, quality of life in patients with migraine, and appear to be very well tolerated. Just to show you. Now, the rimegepant for migraine prevention has been approved, sorry. So rimegepant for migraine prevention has been approved recently. So rimegepant is, as I mentioned before, is a small molecule antagonist, and it comes at 75 milligram dose. Now, if you give it every other day, it has a preventative effect for migraine, and the side effects only include nausea. It has been shown to be effective in randomized placebo-controlled studies, and here we have a phase 2-3 randomized double-blind placebo-controlled trial. And on this slide, you see the change in mean number of migraine days, as well as 50% reduction in mean number of moderate to severe migraine days, much more superior than in placebo group. And here we have atogepant for prevention of migraine. It was approved, and it goes under brand name of Calypta. Recommended doses are 10, 30, and 60 milligrams. Usually we start patients on 60 milligrams dose. The common side effects include nausea, constipation, and fatigue. And atogepant has also been shown to be effective in the randomized double-blind placebo-controlled studies. And here you see the results for the 10, 30, 60 milligrams once daily, and 30 milligram and 60 milligram twice daily, and significant reduction in number of headache days in contrast to placebo. Now, recently we have been using glucosamine for the management of cluster headache. We administer glucosamine 300 milligram on monthly basis subcutaneously for patients for episodic cluster headache, and it's very well tolerated. The most common adverse reactions may include injection site reactions only. This is based on the results on the placebo-controlled trial, which was done for patients for cluster headache, and it showed that there was a reduction in number of days from baseline in weekly days of cluster headaches, averaged over 1 to 3 weeks, in contrast to placebo. I was talking about the pharmacological treatments, but lately there's a big interest in non-pharmacological device treatments of headaches, and so there's a few devices that have been on market recently, and which have been shown to be effective in the clinical trials. One of them is Neurivia. If you can see here, it's prescribed as a wearable device for acute treatment of migraine. It's been FDA approved in May 2019. It uses the so-called remote electrical neuromodulation, and mechanism of action is based on triggering the descending pain inhibition mechanisms, so-called conditioned pain modulation. It comes as a one device with 12 treatments and of 45 minutes each, and you place it on your arm, and it's operated by an app on a smartphone as a smartphone application, and it has also a headache diary, which can give you the information about your headaches, and you can share it with your healthcare provider. Another device which has been on market longer, and it's actually available as over-the-counter now, is Cephali. It's based on the external trigeminal nerve stimulation, and it sends electrical impulses through the electrode position on the forehead, and in this way it modifies the pain transmission and processing in the trigeminal nerve. And so it can be used as an acute and preventative treatment. So as an acute, it's a 1-hour session, and it shows significant pain relief in 8 out of 10 patients, and total pain freedom in 1/3 of patients. For migraine prevention, it's a daily session of 20 minutes. Patients can apply to improve their headaches. The adverse events may include mild sedative effect and some allergic contact dermatitis, which the patient will need to watch for. And the last device which I would like to mention is a gamma core, which is non-invasive vagus nerve stimulator. It is used for prevention of migraine. You do 3 treatments, one in the morning, one midday, and one at night, consisting of 2 consecutive 2-minute stimulations. It can also be used for acute treatment of migraine. And it is suggested that stimulation should be, during the treatment, should be applied on the same side of the neck, and additional treatments could be applied on either side of the neck. And the side effects include application side discomfort, uh, application side erythema, side pain, and dizziness because of the stimulation of vagal nerve. But overall, it's a very well tolerated, and we in the clinical settings we have some good results with our patients. I would like to thank you for your attention. I'm open for questions. Thank you.